Hi, I'm Dr. Polly Watson. Today we're going to talk about some common myths associated with menopause. And after doing this for 20 years, I feel like many times women come in with really fixed notions that may not actually be true, that prevent them from engaging in care that could be really useful for them. So hopefully this will clear some of these myths up and help people feel more confident getting care for menopause transition. So we're going to dive right in with both feet first and really address the elephant in the room, which in my mind is that the myth that HRT causes breast cancer. So where did this idea come from, and why has it been so persistent in the conversation around hormone replacement therapy? So there was a study called the Women's Health Initiative back in the early 2000s that looked at one single hormone replacement therapy formulation. And unfortunately, the results from this study have been extrapolated to all hormones, even though it was only done on one formulation. So the formulation that was used in that study is not one that really we commonly use very much anymore. It was on Prempro and Premarin. So Premarin is pregnant horse urine estrogen. It is an oral estrogen. It's also referred to as conjugated equine estrogen. And in women who had a uterus, they were also given a synthetic progestogen called medroxyprogesterone acetate. So the combination of Premarin and medroxyprogesterone acetate was called Prempro. And in the women who were given the Prempro formulation, they had 3 more incidents of breast cancer out of 1,000 women over 5 years. If we put that risk into context, that's about the same increase in developing cancer if you're sedentary and you don't exercise, or if you have between 1 and 2 glasses of alcohol, or for instance, for wine a night. But we didn't get that information and say, let's get off our couch and let's start moving for cancer prevention. We didn't say alcohol is a carcinogen and is linked to 7 different known kinds of cancer. We just said hormones cause breast cancer, stop taking them. Interestingly, in the conjugated equine estrogen only arm, the women who had had a hysterectomy that were not given the progestogen, they had no increase in breast cancer at all. Since then, we have had lots of observational and cohort studies that have looked at the difference in progesterone or progestogens that were given to women with a uterus and found some differences in breast cancer outcomes in women who were on different progesterone or progestogen formulations. So typically, there's a slight bump in breast cancer risk when women are given a non-naturally occurring progestogen. So what does that mean? A progestogen is a chemical that mimics progesterone. Progesterone is a bioidentical hormone. It's what your ovary makes after you ovulate an egg, and it's something that's naturally occurring in your body. So if you were to take bioidentical progesterone, it's still synthesized, right? It's still made in a lab, but they're mimicking something. It's a chemical copy of something that already exists in your body, whereas a progestogen is a chemical that never existed in nature, but sits in a progesterone receptor. Okay, so what we've learned in the 20 plus years since the WHI is that the type of progesterone given matters for breast cancer outcome, and we can never guarantee anybody that there's no chance of breast cancer. So even in women who are on bioidentical progesterone, it wasn't that they had no incidence of breast cancer. The relative risk of getting breast cancer was the same as their age-matched peer who was on no hormone replacement therapy. So I think that we're coming around to this in menopause society. It's still really frustrating to continue to need to demand clarity when people say hormones do what? If someone's making a claim to you that hormones do something, it's really important to pause and say, what hormones, when were they given in the life cycle, and what was the route of administration, because all of those things matter. So if we're talking about hormone replacement therapy and breast cancer risk, the type of progesterone or progestogen really matters in relation to that risk. And oral micronized progesterone, which you can get as an FDA-approved product, doesn't seem to increase the risk of breast cancer over baseline. But there's still a risk of breast cancer. We live in a really polluted world. There are lots of complicated facts, family history, lifestyle, alcohol use, body mass index, breast density, all of those things come into breast cancer risk. So we can never guarantee anyone there's no risk of breast cancer, but we can make more insightful choices when we're offering hormone replacement therapy. And in the popular press, as well as in the scientific community, we need to continue to demand that people are specific in their language, and that when they're talking about progesterone, they really mean oral micronized progesterone, or they're going to use the term progestogen, which implies that it's a non-naturally occurring compound. So I hope that helps. The second myth is that HRT is just for hot flashes. So I think it's important to understand that hormone replacement therapy is FDA approved only for 4 things: hot flashes, night sweats, urogenital symptoms like vaginal dryness, sexual pain, and the prevention of osteoporosis. So we know that giving estrogen, particularly earlier in the menopause transition, can delay bone loss. There are plenty of other menopausal symptoms that estrogen may affect, and in my clinical experience, it does affect. Estrogen is just not FDA approved for it. So typically we'll see women often come in and say, you didn't tell me that this was going to help my joint pain. And oftentimes women in the menopause transition will have joint pain that will get better with estrogen. Hormone replacement therapy just isn't FDA approved with that indication. We also see improvements in mood and sleep. We can see some cardiovascular protection, particularly when estrogen is given within the first 10 years of the transition. We already mentioned osteoporosis prevention. And then I just want to kind of give a shout out for urogenital health. A lot of us are thinking about vaginal atrophy, or what we call genital urinary symptom of menopause, as just sexual pain, full stop. And some women aren't having penis and vagina sex, and so they may not feel like this is relevant for them. And I just kind of want to give a shout out that regardless if you choose to put anything in your vagina or not, we can have, as we have less estrogen in our vaginas, we will often develop urinary symptoms. So more susceptible to urinary tract infections. The anterior vaginal wall gets thinner, which was where the urethra is sort of running through that anterior vaginal wall. So we have this sensation of, I gotta pee all the time. And so if you have urinary frequency or frequent urinary tract infections, treating with topical vaginal estrogen or vaginal DHEA can really help those symptoms. And it's important to make sure we're offering that to women. Third thing, and we've alluded to this already, but I think it's worth harping on. So the third myth is that all HRT is the same. So I want to make 2 really important distinctions. We've already talked about progesterone, oral micronized progesterone, versus a progestogen, a chemical that never existed in nature, like norethindrone, drospirenone, methoxyprogesterone acetate. So we've talked about that distinction. The other distinction that I think is really important is oral versus transdermal estrogen. So when you give estrogen to someone orally with a pill, you're going to have what we call first pass liver metabolism, and that's going to increase your risk of having a blood clot. So maybe if you've ever taken birth control pills and you've read that package insert, you'll see that there are limitations on giving oral estrogen to women who are smokers over the age of 35, because our risk of developing a blood clot goes up with smoking, it goes up with age, and at the age of 35, the risk outweigh the benefits, and we need to find a different contraceptive option for those folks. Same thing with hormone replacement therapy. There are a lot of observational studies, 20, 30 years of observational studies that have shown that transdermal estrogen doesn't seem to bump up the blood clotting risk. So a blood clot, like a deep venous thrombosis that breaks off and goes to your heart, is a heart attack. One that breaks off and goes to your brain is a stroke. We can minimize or eliminate that risk by using a transdermal through the skin estrogen in the form of a patch or a cream or a spray or a vaginal ring. Those are all ways to avoid that risk. Okay. Fourth thing, HRT causes weight gain. This is so frustrating for so many people. And I just want to say with love in my heart, menopause causes weight gain. So as we're going through this transition and estrogen levels are fluctuating, we become more insulin resistant. What does that mean? So insulin is kind of shaking hands with glucose and pulling it into our cell. If you can't get glucose into the cell, it is going to either deposit in your liver and give you fatty liver, or deposit in your abdomen and kind of give you that apple body shape. So a lot of us will complain that we kind of go from hourglass figure to SpongeBob at menopause transition. And it is so not fun. I totally get it. But it's the menopause insulin resistance that's typically leading up to this, not necessarily are you on hormone replacement therapy or are you not on hormone replacement therapy. There are some large population-based studies that show that women who are taking hormone replacement therapy actually have more preservation of lean muscle mass and than women who aren't. But I think there are a lot of confounding variables there, right? So women who are able to access healthcare, women who are on HRT might be of higher socioeconomic status. They might have more leisure time to exercise. They might have more access to healthier foods, et cetera, et cetera. So I think that's a little complex, but that's the data that we have at this point. We also know that when women are in this transition, they're often having sleep disruption. So sleep disruption is going to screw up everything, right? If you have lower sleep quality and lower sleep hours, your cortisol is going to be up. Cortisol is stress hormone. That's going to cause more insulin resistance. If you didn't sleep well the night before, you're much less likely to meal prep and make yourself this beautiful kale salad with a piece of salmon on it. And you're much more likely to spend an extra 15 minutes in bed and then run out for fast food because you didn't have time to plan. And then because you're tired, you also might be reaching for more refined carbohydrates for quick energy, which are not going to serve, the maintenance of lean muscle mass and balanced glucose. So there are a lot of factors here. I think the other thing that's it's super important to point out is that socially, what is happening in this moment of our lives? A lot of us are balancing caring for older parents that might be needing a lot of support and trying to launch either teenage kids or young adult kids. So there's also a lot of social stressors going on in this chapter that are kind of outside of what's going on with our biology. So women will come into my office and say, put me on hormones so I can lose weight. And then women will also say, you gave me hormones and I gained weight. Menopause causes weight gain. I think where I see the greatest positive health change is if we can get people to sleep, if you can treat their vasomotor symptoms and get them to be able to sleep, then they have the bandwidth to do all the work they need to lift weights, eat more protein, build more lean muscle mass, have a glycemically balanced nutritional load, etc. So hormone replacement therapy doesn't necessarily cause weight gain. If it's out of balance, it can, but most of the time, menopause is just causing weight gain. Okay, number 5, I'm on HRT and my vagina is fine. So I think this is really important to talk about because about 15% of women who are on systemic hormone replacement therapy will still need additional vaginal support. So what do I mean by that? So those women may also have vaginal dryness, sexual pain, genitourinary symptoms, urinary frequency, frequent urinary tract infections, a urethral caruncle. All of those things are going to respond really well to topical hormone administration directly in the vagina. That could be estradiol, that could be vaginal DHEA. We can also use hyaluronic acid. We can use a compounded estriol, although that is not FDA approved in the United States. So there are a lot of options here. I think sometimes women don't seek out additional care because they don't know that they may in fact need both systemic and vaginal support. And it's just really a missed opportunity because it's such an easy thing to fix. Number 6, this is sort of related. So let's say you've tried vaginal estrogen for sexual pain and it didn't work. A lot of women are kind of like, well, it didn't work. There's nothing else I can do. And I want to let you know that there's a whole lot of other things that you can do. Okay. So sometimes with vaginal dryness, particularly in sexual survivors, in cancer survivors, maybe even people who've had pelvic radiation, you may have to layer multiple modalities to help rehabilitate the vagina. You may need hyaluronic acid and vaginal estrogen, or hyaluronic acid and vaginal DHEA. I think another really missed opportunity here is that many women, if they're having any kind of sexual pain, may have secondarily developed pelvic floor myalgia. So tightness in the pelvic floor muscles that is causing pain when they have any kind of penetration. And so often our pelvic floor physical therapy friends can be wildly helpful here, and not accessing that is something that I see missed so often. So women will come in and they say, I'm using Vagifem, or I'm using, whatever topical vaginal estrogen, they're using Permin cream, they're using estrase cream, whatever they're using, and it's not working, and they feel like they're out of options. You are not out of options. Vaginal DHEA acts on all 3 layers of the vaginal skin. And so it's a great option for people who have failed estradiol only. Vaginal DHEA is FDA approved as Enter-Rosa. It's a lot more expensive, but it does work quite well. And then also addressing pelvic floor physical therapy, making sure that vulvar skin issues haven't been missed. And then also just holding space for 1 in 3 women in the United States have had some sort of unwanted sexual contact. So is there a layer of trauma therapy that needs to be offered and addressed to help get past this sexual pain? So if you're struggling with sexual pain and you haven't found hormones to be helpful, there are a lot of other ways to go. I would definitely check out Herman and Wallace. Herman and Wallace trains pelvic floor physical therapists all over the country, and they have a Find a Provider tab on their website. So you might want to check that out to find a pelvic floor physical therapist in your area. Next myth, only compounded hormones are bioidentical. So I get this one a lot because I'm trained in both functional medicine and conventional medicine. I'm often seeing women that are much more interested in more natural approaches. Okay, so what does bioidentical mean? Bioidentical means it's a chemical copy of something that your body already makes. So estradiol is a bioidentical hormone. Progesterone is a bioidentical hormone. When people start using the word synthesized, I don't really know what they mean. All these hormones are synthesized. We're not out back eating wild yams. They're created in a lab. They're just a chemical copy of what your body makes. Okay. So you can get bioidentical estradiol as a patch at the regular pharmacy. You don't have to compound it. If you're not familiar with compounding is a kind of pharmacy where they're making the formulation for each person. And many healthcare providers are a little bit concerned about using compounding because those formulations aren't getting checked by the FDA. Plenty of compounding pharmacies have voluntarily gotten additional government oversight and submitted their products for additional quality assessment. So if you're going to work with a compounding pharmacy, I would ask to look at their accreditation. And oftentimes you can develop a really nice relationship. So I'm not anti-compounding. I think you just have to know who you're working with. Many women are misguided here and spending an enormous amount of money on compounded hormones because they don't realize that an FDA-approved, something that their insurance will cover, hormone is an option for them. So you can use a GoodRx coupon and get an estradiol patch, an oral micronized progesterone, and save yourself a whole lot of money. Okay. Number 8, all libido issues are fixed with testosterone. So, particularly as we're seeing a lot of these hormone pellet clinics pop up, and sometimes more is more in those spaces. I feel like women need a very clear and honest conversation about sexual health and libido. So testosterone does not have a linear relationship with libido, okay? So you can think about this in real life, just in terms of women who have PCOS. Polycystic ovarian syndrome, or PCOS, is a pretty common condition. Women often have too much testosterone that's causing them to be more insulin resistant. They may have some facial hair. They may have some acne. Those women don't necessarily have some knock your socks off sexual desire, okay? So testosterone doesn't have a linear correlation with libido. In the global consensus statement on the use of testosterone in women, when physiologic doses of testosterone are given to postmenopausal women, we see about one more sexually satisfying episode a month. That's it. So we're complicated. Sex and sexuality is complicated. That's awesome. Let's dive into the complexity. Let's appreciate that and have a nuanced and nuanced conversation about this rather than reducing your libido to your testosterone level. It's not accurate. I also think it's not helpful. I'm sorry, I don't want to misspeak. Reducing your testosterone level to libido is not helpful. Testosterone can absolutely be helpful in some people. It is just one piece of a very complicated puzzle. Okay, number 9. If I can't take HRT, so what would be the reasons why you couldn't take HRT? Maybe you had a hormonally sensitive cancer like breast cancer. Maybe you'd had a blood clot or a stroke or a pulmonary embolus. Maybe you have an inherited blood clotting propensity like factor V Leiden. For whatever reason, you were told that you can't take hormones. There are some new options. So Veozah is a newer medication that acts on the brain and acts on the brain signaling to the hypothalamus and blocks the thing that's triggering the hot flash. That has been shown to reduce hot flashes by about 85%. It's been really effective for managing symptoms. In the pipeline, in stage 3 trials, there's something called E4. So this is a bioidentical estrogen, which is made during pregnancy in the fetus's liver. And this can be synthesized in a lab. And it has some really promising data that shows that it can help with hot flashes and night sweats but has no effect on the breast and no effect on causing blood clotting. So this is in stage 3 trials now, and I'm really excited to see it come out for the menopausal. Give us some more options for the menopausal community. Last myth. You can't take HRT until you're fully menopausal, meaning that you haven't had a period for a year. So we do know that perimenopause can last from between 2 and 8 years. So telling women that they're just going to have to suck it up for 2 to 8 years is unreasonable. And many times in this period, women are just sort of offered low-dose birth control pills. But some of us either choose not to take birth control pills or have had negative effects with birth control pills and don't want to take them. So in those populations, we can certainly offer transdermal estradiol and micronized oral progesterone to help moderate these symptoms even while they're having a period. Oftentimes you'll cycle women's progesterone with their period to kind of help manage bleeding issues, but you don't have to haven't had a period for a full year before you start hormone replacement therapy. So I hope this was helpful in trying to get some of those myths out of the way with hormone replacement therapy. And I hope it gives you more confidence when you're going in and bringing up some menopausal concerns with your healthcare provider. Take care. Thanks for listening to Menopause Rescue. We hope you've enjoyed this podcast and it helps you create some time and space to make this the best half of your life. If you've enjoyed this content, please leave us a 5-star rating and review. This helps other listeners find this resource and rescue and restore their health.